Assalamu alaikum warahmatullah. Thank you for the organizing committee for the kind invitation. This case is actually designed to be live in a box, but it's going to be more interactive. We have both all audience today available today. So the learning objectives from this presentation is going to be talking about life management of severe aortic stenosis using Tavi platform. Then we're going to talk a bit about Tavi and bicuspid aortic valve. Then we'll talk about optimization of the coronary access using conventional alignment with the new generation of Elliott FX. So it's going to be done through a case presentation. A 76-year-old female known to have diabetes type 2, hypertension, and dyslipidemia. She came to our center with a non-ST segment elevation myocardial infarction. At that time, her ECG showed non-specific ST wave changes without ST elevation. So transthoracic echocardiogram for her showed heavily calcified aortic valve. And as you can see in this lumbar sentinel view, you could appreciate that incomplete prolapse of the cusp, suggestion of the bicuspid aortic pathology. Again, heavily calcified, and you could appreciate here clearly that the aortic valve is calcified with bicuspid aortic pathology, and ejection fraction of the LV looks preserved around 40% based on transthoracic echocardiogram. We went ahead and did for her left coronary angiogram, which showed basically severe disease at the ostial LED with focal lesions involving the left circumflex system in the mid-segment and in the OMs. Again, the LED looks somehow moderate lesion in the mid-segments, and again, severe narrowings in the proximal and mid-right coronary artery.
So basically, Abdullah, ostial LED and
Right.
LED diseased, and dominant CERC or co-dominant CERC and extensively diseased, and the RCA also is extensively diseased. Yeah, go ahead. Show us the CT.
So we went ahead also and did cardiac CT protocol, showed basically confirmed our finding by having basically a severe type 0 bicuspid aortic valve, heavily calcified with no repair. The calculated actually parameter at the level of the annulus was around 80. There was no major problem with the coronary height on right and left. And there is also no major concerns regarding the access from right or femoral artery.
So, Dr. Muhammad, so here the membranous septum, we did not mention it, was about 4 millimeter only. Usually the membranous septum in female usually is short because by default the heart is small in size but is big in capacity. And so, Dr. Muhammad, your approach, please.
Approach to what? To the septum or to the patient?
Seriously. To the extensive coronary artery disease.
This is.
Show us the angio again, please.
No, this is fine. This is severe 0, 2 cusps, pure 2 cusps, 2 commissures, and there is calcium around. So there is no issue of Rafi or all these things. These are seriously underrepresented in Tavi group. The majority of bicuspid Tavi is Seifers 1. And we take care of the Rafi, and we calculate the Rafi, and we fracture the Rafi, and that's the contact, first tissue contact. So here, we don't know how to calculate it. Probably we'll calculate it like the tri-leaflet, but we have to predict the behavior of the calcium at the edge. This is number 1. 2, coronary. She presented with heart failure. I will not touch the coronary.
No, non-STEMI, sir.
Sorry?
Non-STEMI.
Okay. I thought it's heart failure.
Yeah.
So non-STEMI, what is the culprit?
So that's a difficult question. So you have this ostial LED and proximal, and you have this ugly CERC dominant. So would you fix this? First of all, she declined surgery. By the way, we, give her the option. She totally declined surgery. So now we left with this scenario: type 0, extensive coronary artery disease.
So I will make sure that I discuss her in the heart team meeting.
It is in a heart team meeting.
And I will make sure that I get support from the heart team meeting. I will go with the surgeon to the patient, and we will talk to the patient about the pros and cons of every approach. And I think the best way is a complete fix, and the best way is surgery in this patient. There is no doubt, because bicuspid is a different enemy or animal, and the three vessel disease. So it goes for surgery. Now, if she given time and she refused, I will, from the echo, I will try to figure out what is the culprit. I will fix the coronary culprit. But I will not go dilating everything because this really doesn't help. So if it is acute coronary syndrome, non-STEMI, I will fix the culprit. I will do my best to know the culprit, fix it.
Sure. So the echo, Abdullah showed you there is no regionality. But the troponin was 4,000.
That's a trap.
Yeah.
Because I don't believe in hemodynamic assessment and FFR, IFR in non-STEMI. So I will probably do, if there is imaging, I will do contrast-based imaging, like OCT, try to figure out, to find out, is there a black rupture, which denotes the culprit, and I will fix it.
Faisal.
Do you think?
Go ahead.
Professor, go ahead. Do you think you should do both? It should be done in one mission, or you can staging the things. And if you would like to stage, you will start with valve or with the coronary.
Yeah. So Faisal, that's a very valid point, but tell us what's your approach and which valve?
So not to dwell, again, Dr. Mohammed highlighted important points, so as the panelists and you guys.
I ask your opinion, Faisal. I know.
So this is a bicuspid valve type 0, and again, there is limited data for certain platform. You do have coronary artery disease that you need to deal with. I missed the coronary height. What was the coronary height?
It was high.
It was really high.
And here.
It was good. So on the right, it was around 19, and the left was 15.
Excellent. And if you don't mind, just the age of the patient.
76.
And you have an area of how much?
The area for at the annular level, it was around, the parameter, it was 25. And,
The area? Clearly, you do not deal with balloon expandable valve, but I personally, in this case, it's a type 0, and I could use a balloon expandable valve, assuming the area is more than or equal to a 23 millimeter valve. The tricky question is revascularization. In this specific case, you need to be prepared to do it both in the same setting. Personally, I would start with the valve.
طيب, last question. Ahmed al-Shatti, which valve are you going to use? كلمتين ورا الغطاء يا عبد.
I came late, but I would use balloon expandable.
Balloon expandable.
For type 0, I always use.
Abdullah, you did the presentation, amazing presentation. Which valve? Okay. So we're going to fix the coronary before Dr. Muhammad, or we go with the valve first?
No, of course, I will fix the coronary. It's the presentation. She came with non-STEMI. I will not entertain the Tavi now. I will go for the coronary, fix the coronary, and then I don't have to do it at the same session. Let her settle down, and I will plan her to fix the aortic valve.
So that is the message. If there is acute coronary syndrome, you should go 30 دقيقة فوز. You should go for the coronary first, and then if heart failure, you go for heart failure. Abdullah, go ahead.
Okay. So for this patient, for all the reasons mentioned, we decided to go with the PCI and Tavi. Our option here, since she presented with ACS, is to go first of all to PCI. And looking at the lesion itself, actually, in the LAD, we're anticipating we're going to send the left main because it's all ostial lesion, the LAD with the no landing zone. So for our decision regarding the Tavi, when we do balloon sizing, usually for bicuspid valve, we depends on the CT images, and sometimes we do balloon sizing in selective cases. Looking at the balloon sizing based on the CTs, we have nowadays probably 3 methods. The first method called Bavard method came from Bavard registry. And at this method, you say that clearly you can do the sizing based on the annular parameter derived in 90% of cases. Having said that, you have to ensure that the annular diameter and the ICD, which is intercommissural dimensions, which is 4 millimeter above the annulus, is actually equal, or the ICD is bigger than the annular diameter. However, if the case that you're dealing with the basically the annular diameter bigger than the ICD, then probably this is what we call tapered configuration. Then you can go probably with the ICD measurements for the annular for Tavi. This is basically probably the only protocol or the validated for patients who came with type 0 aortic valve. Because the other protocol or the other methods like LIRA based basically on the Ravi level or the Casper algorithm, which is basically a combination of using the calcium score and the length of the Ravi, has been only validated in patients with Ravi type, basically severe aortic stenosis. Going back to our patients, basically a patient has type 0 bias Casper aortic valve. Looking at the annular configuration, when we measure the parameter derived at the level of annulus was 80, while at 4 centimeter, the level of ICD was around 72. So we're dealing with tapered annular configuration. Based on our measurement, if we're going to go for 80 millimeter, then we're going to use 29. And if we're going to go with this one, it's going to be 26. So we lifted up with having 26 balloon. However, we want to confirm basically our findings. So we went with using sizing for balloon. Currently, there is no protocol again for using balloon to size patient with bicuspid aortic valve. This is probably the best protocol coming from Chinese study done basically in those patients, and clearly said you take the balloon at the lower or the minimal diameter, then you inflate this balloon and try to see if there is a waist sign happening also with less than mild regurg happening during the balloon inflation. Then if that happens, then probably you're going to go with the size based on the diameter of the balloon used and the parameter derived of annulus divided by 2. If this is not happening, then you're going to go with sequential upsizing the balloon until you get this result. Then you do the same as here.
Abdullah, just 1 second. So the sizing, it depends on the platform you want to use. I love self-expandable valve in bicuspid aortic valve. Very nice illustration, Abdullah, but I will tell you the way I do it, then we're gonna go to the case. If there is 2 ways, if you are using a balloon expandable, either the simple blunt way is to use what you see in this picture, is you go, usually the intention with bicuspid is, usually if the annulus take, let's say 29, I usually go to the number below, like I downsize because we don't want any enfolding or any problem with the valve. So if the LVOT is generous, is equal to the annulus, and there is no calcification, I will stick with the number they give me, plus I do the sizing balloon. If the LVOT is small and the valve is calcified, I usually downsize. I do all my exercise to put, if it's 29, I will go with 26. I will show you now the demonstration.
All right. So back to this patient. We brought it another day. That day we did basically PCI to the circ. Then we have to do PCI to left main circ using tap technique. Then she was, again, after a few days, we brought her this time for PCI to the RCA, and then considering also Tavi on the same session. So we managed to do PCI to the RCA with a single stent, and with each inflation, she developed hypotension and chest pain. So we decided to basically move to basically putting the valve, then deal later with this under expansion in the middle of that stent. So at this stage, basically, we're assuming we're going to use supraannular measurements, 26. We use the balloon sizing, and we went here with a 26 size balloon. So inflated, and basically, as you can see here, during the inflation, I'm going to show you here, yeah. So during the inflation, we did basically injection to see if there is any contrast leaking, or and there is some waste. So we are sure using 20 balloon is actually going to seal the annulus at this level, confirmed our finding in the CT finding by doing basically 26 size valve. So this is basically another important consideration with the new valve, using the dots to guiding basically your deployment. So the dots are going to help you. You're going to go with the cusp overlap views, basically to look for the 3 dots position in relation to this view. So if you have...
Sorry, Abdullah. So the 3 dot, the message I want to relay here, is not only for looking at the level of the implantation. Now we use the 3 dot to look for commissural alignment. And I want you guys, we are really focusing on this because this is underutilized. We use the 3 dot for commissural alignment. Abdullah will show you now. It's not only for the level, it's to also do proper commissural alignment. He will give you the normal dot shape in each view to make sure that you are having a good commissural alignment, in addition to what you know from the hat marker. Like in cusp overlap, it has to be in your face. And when you go up, it need to be in the greater curvature. Now he will show another trick is to make sure that you are having commissural alignment. If you don't have it, pull it out, recapture, and go in the descending aorta, and go back after you do a good 3 o'clock rotation.
So these basically additional important things, especially in this patient with underlying stance of left main. So you look for the 3 dots in the cusp overlap view. And ideally, if you achieve this configuration, having 2 of them on the left side, and basically one of them close to each other, the other one to be in the left side, like on the right side, like in this view, probably you achieve complete, or I'd say excellent commissural alignment. However, if all the 3 come in the mid side at the same distance, so one here, one there, and one here, then probably you achieve partial commissural alignment. Of any other configuration, like if you have both of them on the right side, then probably this is not excellent, I would say, unlikely you have commissural alignment.
So the 2 dot will be on the left of the screen. This means good commissural alignment. If they are on the opposite side, on the right of the screen, you have most likely complete malalignment. If it is in the middle, it's partial malalignment. This is very important.
So after that, it was straight out to procedure, deploy the valve as usual, and just gonna play it here. Right. So this is basically the end result of this stage, and you could appreciate there was actually no leak, and the gradient that was in this patient was 0, calculated invasively. Good access, you could see that by doing aortogram. We did also assessment using left coronary assessment to basically, as we usually do in our daily practice, to that we have a good actually commissural alignment with easy access in case this patient needs an intervention in the future. At this stage, we went back also to the RCA. The patient was now stable. We did balloon inflation using DNC balloon. And this is the final results. Thank you for it.